Hi guys, thank you for watching my channel. Today we are going to discuss the management of hepatocellular carcinoma. Hepatocellular carcinoma is a relatively common problem, and worldwide it's a significant disease burden where almost 1 million people die, in fact, annually from hepatocellular carcinoma. As we know, primary liver cancers, majority of them are hepatocellular carcinoma, 80%, and the rest of them are cholangiocarcinoma. But today, particular topic is going to be about hepatocellular carcinoma. The disease is particularly common in China due to the fact that hepatitis B is an endemic disease in China and Southeast Asia. Usually these patients have liver cirrhosis. Any patients who have liver cirrhosis will be at a high risk of developing hepatocellular carcinoma. And almost 95% of the times when we see hepatocellular carcinoma, it is seen in patients with liver cirrhosis. The incidence of hepatocellular carcinoma is increasing in the West in the last 2 or 3 decades, and this can be explained by the increasing incidence of hepatitis C infection among people who inject drugs and needle sharing, and also the immigration pattern to the Western countries. And if we look at the world map here, we see China and Southeast Asia is the most common place where you see hepatocellular carcinoma. In Egypt as well, due to hepatitis C, sub-Saharan Africa, and in Europe and in America, the incidence is going up as well, relative to Australia and East Africa, Russia, and Canada, where hepatocellular carcinoma in general is not a very common disease. Despite that, we do see these cases relatively frequently. Now, we will need to talk about the etiology, the causes of hepatocellular carcinoma. Any disease that lead to liver cirrhosis and chronic liver inflammation, chronic hepatitis is a cause for hepatocellular carcinoma, and that include hepatitis B and C, alcohol. Now we see increasing patients with no other risk factors for hepatitis and hepatocellular carcinoma, but they are obese, particularly people with obesity and diabetes. They will develop what we call non-alcoholic steatohepatitis, NASH. And this is of increasing concern, where the people get liver cirrhosis in the absence of other risk factors. Hemochromatosis is an uncommon disease. It's autosomal recessive, and we have a lot of carriers, but the disease itself is not a common condition, but it is a known cause for liver cirrhosis and hepatocellular carcinoma. Alpha-1 antitrypsin deficiency, this is rare disease, and there are other illnesses that can lead to liver cirrhosis, such as the Wilson disease due to abnormal copper metabolism. There is one thing that we need to notice about hepatitis B is the fact that with patients with hepatitis B, they could develop hepatocellular carcinoma without having liver cirrhosis. And the reason behind that is the RNA of the hepatitis B virus will get integrated into the DNA of the hepatocytes, and that by itself is an oncogenic process. So these are the main causes of chronic hepatitis and hepatocellular carcinoma. From pathology point of view, if you describe the tumor in terms of microscopic or gross appearance, there is the hanging type. It's quite uncommon, but it hangs out of a vascular pedicle and superficial and easy to remove. The pushing margins, tumors with the pushing margins, that constitutes the majority of cases of hepatocellular carcinoma. There is infiltrative type, which has ill-defined margins, and this type is particularly nasty, and we've seen it usually in patients with hepatitis B. The disease tends to be advanced at the time of presentation, and it's very aggressive, progresses and recurs rapidly, and usually is a fatal condition. An important characteristic of hepatocellular carcinoma is the fact that it could be multifocal. So because of the process of cirrhosis, the high DNA synthesis will lead to increase the risk of mutation and oncogenesis. So the liver will be a fertile soil for a new hepatocellular carcinoma to grow in it after the initial one has developed, which means that there is a high recurrence rate. There is particular tendency of the hepatocellular carcinoma to invade the branches of the portal vein, and this can lead to thrombus, a tumor thrombus in one of the major branches of the portal vein, which can eventually extend into the portal vein itself or metastasize inside the liver, and they tend not to do very well in the long term. Vascular invasion is a bad prognostic sign generally for hepatocellular carcinoma. Now, how do these patients present? Luckily, we have surveillance systems where any patient who's got chronic active hepatitis or liver cirrhosis, they will get 6-monthly ultrasound scan and alpha-fetoprotein in order to find about these lesions and tackle them early in the pace. However, some patients are not under surveillance because they have not been referred to a specialized liver clinic, and they can present with right upper quadrant pain, right upper quadrant mass, constitutional symptoms such as weight loss usually. The lesion could be large and sitting in the central part of the liver, close to the hilum, where it will lead to blockage of one of the bile ducts or the main bile duct and lead to obstructive jaundice. Hepatocellular carcinoma is known also on rare instances to rupture and bleed heavily, and we see that every now and then, and that is when they rupture. In fact, generally the prognosis is not that good. Some patients are known to have liver disease, and they present with decompensation or sudden deterioration in their liver function tests and decompensation, and that's often due to development of malignancy. Now, when we assess any patients with hepatocellular carcinoma, we have to take into consideration two problems. We are really dealing with two disease issues. One of them is the chronic liver disease, and the other one is the cancer itself. With the cancer characteristics, I want to emphasize the importance of the most important prognostic signs on which most of the staging systems have been developed. These are the size of the lesion, the number of the lesions in the liver, and the presence or absence of vascular invasion. That actually determine the stage of the disease, as we will see later on in this lesson. This is an MRI with Primavist for a patient with multiple hepatocellular carcinoma, multifocal. And that's how it appears in the hepatobiliary phase of MRI, if you remember from the previous session on imaging liver masses. This is a delayed hepatobiliary phase. The normal liver parenchyma is whitish to gray, and the liver cancers or the nodules of tumor are dark gray. Now, there is a very important thing here, as we said, that we need to stage these two diseases. So we'll start how to stage the chronic liver disease, the underlying disease. There are two systems. One of them is the Child-Pugh staging system for chronic liver disease, and the second one is the MELD scoring system. The Child-Pugh is widely used and has been there for several decades to stage liver disease, and the MELD score is more recent and it's more useful in patients who need liver transplantation. The Child-Pugh scoring system relies on two clinical features and three biochemical features. The two clinical features that we will discuss are the encephalopathy and the ascites or portal hypertension. Now, how do we know the patient have got encephalopathy? The patient themselves might report a bit of drowsiness and memory changes, but usually their relatives, their spouse, will notice these changes on them more than the patient themselves. So they will have behavioral changes. They will notice that their memory has deteriorated and they are drowsy and they sometimes need to sleep during the day. The second part, which is the portal hypertension, this is either manifested as ascites, which indicates a decompensated advanced liver disease, and the varices, which also denotes an advanced liver disease. Occasionally, portal hypertension is not seen clinically, particularly if it is in the early phases where we get hypertension without these changes, and that can be seen on thrombocytopenia or when we measure the hepatic venous wedge pressure to see how high the portal pressure is. The biochemical features, these are tests that we do through the blood, and they measure the synthetic function of the liver. And they are the bilirubin level, albumin level, and the prothrombin time, or the INR. While the MELD scoring system, which is used in liver transplants, relies on the bilirubin and the INR as part of the synthetic function, and it also takes into consideration the kidney function in the form of creatinine and the sodium level, because a lot of patients who have chronic liver disease, they could develop the hepatorenal syndrome where their kidneys start to fail consequently as a result of the problem. And generally, these two scoring systems, very easy to calculate and easy to implement in clinical practice. They are available on apps on your iPhone, and you can download the app, and you can calculate the individual scores for your patients. So now we move to staging the liver cancer. As I mentioned earlier, tumor size, number of lesions, vascular invasion are the mainstay to stage liver disease. These patients do get chest, abdomen, and pelvis CT scan. We don't use PET scan in hepatocellular carcinoma because it's not very accurate, but the CT scan will show us if there are metastases. It often does metastasize to the lungs or to the bones. We, in certain stages, take some other consideration when the disease get staged, such as the level of alpha-fetoprotein. So if the level of alpha-fetoprotein is less than about 400, that means that there is unlikely to be distant metastases or advanced disease in the liver. The more the level goes up, the worse the outcome, and the more the likelihood that the cancer has got either vascular invasion or distant metastases. So we take all these factors, as I said again, this is a repetition of the vascular invasion, the distant metastases, and lymph node involvement. But I need to warn you that lymph nodes in hepatocellular carcinoma and their staging is not well studied, and it's not taken into consideration. Although we do have a staging system, which is the American Joint Cancer Committee, that utilizes the TNM classification, but it's too complex and not very useful clinically. One of the outstanding systems for classification of hepatocellular carcinoma is the Japanese or the Okuda staging system. And that, as you see in this table, relies on the tumor size and whether the tumor occupies less than 50% of the entire liver volume or more than 50%, and whether they have portal hypertension in the form of ascites or not, and the level of their albumin, whether it's less than 3 or more than 3 grams per deciliter, and also the level of the bilirubin on the same number, less than 3, more than 3, if you are using the milligram per deciliter. The Okuda staging system is well studied and has been investigated for a long period of time, and it's very effective. However, from the MD Anderson Cancer Center comes the VOTI classification system, and it's has been devised and validated. It's a very useful staging system as well. It's simple to use and reproducible. And that divides liver cancers into 3 stages. The A stage, which is when you have a single tumor and there is no microvascular invasion on the capsule, on the microvascular invasion or capsular invasion, on the histopathology, and the tumor, usually the largest, should be less than 5 centimeters. It would be stage B when you have a tumor, a single tumor, less than 5 centimeters with microvascular invasion, or you have multiple tumors, none of them more than 5 centimeters. And stage C, you either get multiple tumors with one of them at least 5 centimeters or more. The other alternative is when the tumor have major vascular invasion. And that's the vascular invasion that we will see on the CT scan and the MRI, rather than the microvascular invasion. This system is a good one to rely on for staging patients and stratify them to what sort of treatment they will be entitled to, or they will benefit from. Now we need to know the available treatment options for us in treating hepatocellular carcinoma, and in here I have divided them into 3 categories. We either treating the patient on the basis that their disease is potentially curable, so we provide them with potentially curative treatment, and that is either resection or ablation for tumors less than 2 centimeters. In this situation, it has to be less than 2 centimeters, or they get a liver transplant. The second category is the liver-directed therapy, and the liver-directed therapy is things that we do in the form of either chemotherapy or radiotherapy to treat the liver. So TACE stands for Trnas-arterial chemoembolization. It's done by interventional radiology. The radiologist will go into the femoral artery, cannulate the celiac axis and up to the hepatic artery, and then do selective arterial cannulation to embolize a lesion like that. And embolization usually with chemotherapeutics. And the most utilized form of chemotherapy and studied is the doxorubicin. It's a very effective form of treatment and has got a survival advantage over other forms of treatment when there is no curative option available. There is another option, it's called the SIRTEX, which is selective internal radiotherapy for the liver. The difference is TACE, or Trans-arterial chemoembolization, is selective. It will go to the tumor and possibly small part of the parenchyma around it. But with the SIRTEX, it has to usually involve half of the liver or the entire liver. So the SIRTEX will get chosen when we have multifocal tumor, which is bilobar, distributed in both lobes, while TACE is done for a single, usually single lesion. That's when the patient is not suitable for surgery because the disease is advanced and their liver is failing. Now, systemic chemotherapy, variety of chemotherapeutics have been used in the past to treat hepatocellular carcinoma, and this varied from doxorubicin to a lot of variety of other chemotherapeutic agents, but the benefit has been unfortunately minimal. More recently, the tyrosine kinase medication has been designed, and they are monoclonal antibodies, that can attack the cancer cells. And we have available sorafenib, and there is at least another form of tyrosine kinase inhibitor that's there, but they are usually used in recurrent disease or people with distant metastases, and they might have a survival advantage of a few months over the best palliative treatment. Now, when we treat hepatocellular carcinoma, we need to categorize these patients according to the stage of their liver disease and the stage of their cancer. And I have chosen this algorithm for you, which is based on what's called the Barcelona Liver Clinic for management of hepatocellular carcinoma, which divides the patients, or stratify them rather, into three categories: A, B, C, and D. A is the early disease, where the early disease is defined as a single or up to 3 nodules, but the largest should be less or equal or less than 3 centimeters. So that's the condition of being into the A stage. Into the B stage, we have usually multinodular disease, and usually none of them is bigger than 5 centimeters. While in the advanced stage, we have extrahepatic metastases, and in the terminal, where they have got no chance of cure, where they have advanced cancer and advanced liver disease, and they will have only symptomatic treatment. So I will make this a bit simpler and easier for you to remember. So we take, if the liver is well compensated and the cancer is early, then they qualify for curative treatment, and that would be in the form of resection. So we've got early cancer and early liver disease, we resect. If we have got a patient with advanced cancer and their liver disease is not suitable for resection in that case, while their liver underlying status is compensated, then they can have Trnas-arterial chemotherapy. Also in this category, sorry to track back, we will have some patients who will have a bad liver, where they have got advanced liver disease, decompensated liver disease, but the cancer is early, and then they will be suitable for transplant. While the extrahepatic metastases, they will only qualify for systemic treatment that might give them a few months extra, and those with advanced both liver disease and cancer will be only suitable for symptomatic treatment, which is palliative. So again, I will emphasize that the previous slide might be a little confusing, but you will need to spend some time with it to figure how it actually works. And I could make it easier for you in this slide by saying that we divide the Barcelona staging system in a simplified way into 4 stages. So we've got bad liver, bad disease, and we've got good liver, good disease, and we marry these to each other, and we'll get 4 possibilities. where the tumor is early, and as we said, an early tumor means that no more than 3 nodules, less than 3 centimeter, and their liver is compensated. These patients will have resection or ablation. And we use ablation with microwave or radio frequency when the liver lesion is less than 2 centimeter. More than 2 centimeter, they do better with liver resection. The second possibility is that we have got an early tumor, but the liver is decompensating liver. So these patients will benefit from transplant because they have low risk of recurrence of their cancer, and their liver is late B or child PUC class. And these patients they do better with transplant, and there's good survival results up to 70% for in 5 years' time. The other possibility is that we could have advanced tumor and the liver is still compensating, which means that they are either A or the good B, where they are not, where they don't have massive ascites or portal hypertension. These patients will benefit from liver-directed therapy in the form of TACE or SIRTEX that we mentioned earlier. And the fourth group is the advanced disease, where both the tumor is advanced and the liver disease is advanced. And these some of them can benefit from systemic treatment if they have got good performance status. But if they have got poor performance status, then we do palliate them and treat them only symptomatically. So I hope this slide will make it easy for you to understand the disease classification according to the Barcelona clinic, and I made it simplified a bit more than the previous algorithm. Now I have to mention to you the median survival. In terms of prognosis and survival of these patients, these are a few studies that have calculated the median survival in months for patients with the Okuda or the Japanese classification system, stage 1, 2, and 3. And we see here that the median survival is around the 30 month in general, 33, 32. So it's around the 30 months. This is median survival. While stage 2, it seems to be, the median survival seems to be just about a year. And those who got stage 3 disease, these patients, majority of them will be dead in a matter of 6 months, unfortunately. And that does apply for a majority of people with liver cancer, because almost 80% of them will present late because they had no symptoms or they have been referred, and only a small fraction of them will be suitable for the curative treatment that include either resection or ablation or transplant. With the 5-year survival, this is from the surveillance, epidemiology, and end results group. The data showed us the 5-year survival here according to the stage of the disease, and this staging is more or less similar to the Okuda, but it's more in fact the Vauthi classification system. And then we have the early cancers where the lesion is less than 2 centimeters single nodule. They have a survival of 70%. Localized disease, which that means that disease that is resectable, still localized to the liver, no major vascular invasion, and these patients will have 34% 5-year survival. And the regional, it means that the disease is locally relatively advanced, and only 12% of them will survive to 12 to 5 years with treatment. And people who've got distant metastases, their chances of 5-year survival are very small. I hope this lesson has been beneficial to you and hopefully not too confusing. I tried to simplify the topic as much as I can, and I would be very interested in your comments and suggestions. And thank you for watching me again, and please subscribe to our channel to keep us going. And I will see you in the next lesson.